We're going to go ahead and record this so that all of this will be available to our wonderful colleagues who aren't available to attend today, but will be able to have this viewed on their own time, which will be fantastic. So give me one moment here, please, while I flip screens. And I am absolutely delighted to lead off by introducing Dr. William Calo. So Dr. William Calo is Assistant Professor of Public Health Sciences here at the College of Medicine and a Latino Health Services researcher. His research program examines how to adapt, implement, and evaluate evidence-based interventions to improve cancer prevention and control among diverse and disadvantaged populations. Dr. Calo is currently focused on the impact of interpersonal systems and policy strategies on HPV vaccine uptake in rural communities and the implementation of locally tailored programs to improve physical activity, nutrition, and community clinical linkages. He applies implementation science methodologies in his studies, and I'm absolutely delighted to also share that he's joined our CTSI and his implementation science core with support services in this really exciting area that the CTSI is looking forward to growing into. So with no further ado, Dr. Calo, please take it away.
Thank you, Jen. Can you all hear me? If you can, okay, perfect. So let me start. I wanna first of all, thank you for the invitation, and feel free to use the chat box if you have any questions, or just keep any questions that you may have to the end of my presentation. I plan to talk for the next 30-35 minutes, and hopefully we can have a discussion at the very end of my presentation. So we're talking about something that I have been working with some of you for the past 2 years, is the ISC, or Implementation Science Collaborative. And the goal here is to advance health equity through implementation science, how we can speed up the implementation or uptake of evidence-based innovations in our catchment area or our region to improve health equity. I'm gonna be moving slides. Give me one moment. Let's see. Perfect. The outline for my seminar today will include why we're focusing on implementation science, a few key terms and concepts that are critical to understand this growing field. I also want to spend some time talking about TMF, or theories, models, and frameworks, a little bit of discussion about some research designs that we use in the field, more specifically about hybrid models, and also key distinctions about implementation strategies. And I think at the very end, the last 10 minutes, I'll focus about what we have accomplished or achieved in the last 2 years in terms of projects, services, and future directions as we move our services or expand through Penn State CTSI. I like this slide a lot. I think it summarizes what we try to accomplish with implementation science. I think you all have know the concept of the know-do gap, or this gap between what we know and what we do, what is actually implemented in healthcare services or community settings. So I wanna give this example in the context of exercise oncology interventions, or the context of chronic disease prevention intervention. So we know that exercise, we know that healthy diet helps to prevent chronic disease. It helps with cancer patients through their treatment recovery. But we know that not everybody is taking these interventions. And the second thing is that we know that not all clinicians are assessing patients for recommending or referring to these interventions if they need to. So what implementation science tried to do is to serve as a bridge between what we know it works for those evidence-based interventions and what we would like to do, or what we should be doing more efficiently. I want to start with a few key terms here, and probably these next 2 minutes will be a little bit boring, so stay with me because it's important just that we understand the concepts in the field. I think many of you have heard this term D&I, and that means dissemination and implementation research, or science. So dissemination research is a scientific study of target distribution of information or intervention materials to a specific population or audience. So dissemination research focuses more on the distribution, okay, the dissemination of that information or interventions. It does not take care of the implementation or optic. The second concept is implementation research, and that is the one that focuses on the strategies to adopt or uptake these evidence-based interventions into these clinical and community settings. So I think it's very important that we understand the difference between the dissemination and the difference with the implementation. Not all the D&I studies focus on both things. Actually, if you look at the NIH portfolio, you would see that probably 85–90% of the funding research on this space of D&I focus more on implementation research. Okay, and there's a recent call from NCI, more specifically about funding more dissemination research projects, specifically in some areas of cancer communication. Another term that I want to focus, and I have been talking a lot about interventions and strategies, is what is an evidence-based intervention? These are programs, practice, guidance, or policies that we know work. They have been tested, and we know that they're effective to improve health behaviors or health outcomes. The second thing, or the second concept, is an implementation strategy. And these are the methods, techniques that we use to improve the adoption, implementation, and sustainability of these evidence-based interventions. And I think that's very important, that when we write grant applications or papers, we make an effort to distinguish them, because they're not the same, okay? The intervention is the thing that you wanna implement, and the strategy is the mechanism to implement the thing. And I will show you that in a moment. So this is a lot of scientific terms, but I have found this picture here very useful. And this is how we define implementation science in a non-scientific language. So let's start here. The intervention, practice, or innovation is the thing, is what we want to implement. Effectiveness research look at whether the thing works. Implementation research looks at how best to help people or organizations do the thing or implement the thing, the evidence-based intervention. Implementation strategies are the stuff we do or the things we do to try to help people or places do that thing. And lastly, implementation outcomes are how much and how well they do the thing. So again, if you want to do this in a non-scientific language or terminology, nomenclature, the thing is what we want to implement, the intervention, practice, and innovation. And the strategies are the stuff that we do to implement the thing with people or in places. Okay, so I hope that is clear. And I think it's important because one of the main critiques that reviewers give in grant proposals is that most of the time the evidence-based intervention, the strategy, are not well defined in grant proposals or papers. And I'll show you some examples about how you can improve your writing skills, specifically for the implementation science field. So let me do another distinction here. And this is between clinical research and implementation research. So the first column show you some study features, and the second and third column show you some study types. The second column is about clinical research, and the last column is about implementation research. When we do clinical research, we want to evaluate a clinical intervention. And usually that intervention focuses on drug, procedures, therapies. The outcome is usually a health outcome or a behavior change or a reduction in symptoms. And we usually analyze this at the patient level. Of, yes, there's some clustered trials that we do in a different way, but this is what clinical research do. Implementation research is not focused on the intervention. Remember, that's the EDI. That's the thing. Implementation research focuses on the strategy, the stuff that we do to help with the implementation of the thing. Typical intervention is focusing not on a drug or a therapy or a procedure, it's focusing on practice change or training. And I'll give you some example about what I'm doing with Project ECHO lately. The typical outcome is nothing related to health or behavior change among patients or population. It's about the adoption, fidelity, level of implementation, sustainability, cost among clinic, healthcare teams, some facilities that may include schools or other settings. I'm working with Katie Schmitz, and she's doing some work in YMCAs. I'm doing some work with Jim Krasnowski right now in WIC offices. So implementation research is not only focusing on the healthcare setting per se, but also is moving how we can implement some of these innovation in community settings. And I think that's one of the focuses on health equity, how we can move some of these innovations to reach population that they don't frequent healthcare systems, especially minorities, some people in rural areas, but they have other places that can support the delivery of this innovation. So I want to make the distinction here. What's clinical research, what's implementation research? There's something called hybrid type 2 designs that I will describe in a moment that allows researchers to conduct randomized controlled trials to answer both questions, a clinical question and the implementation research question. So basically, when we do research, most on the clinical research field or the public health field, we focus on the what, that evidence-based intervention. We implement the intervention, and of course, we expect to see some changes in health outcomes, satisfaction, function, health status, symptoms, and some other things. So that's the usual way that we do our work. We implement something and we expect to see those changes. But a lot of the time we miss that picture that is in the middle, how we implement that. If we see the change in health outcomes, how that change is happening and why is happening. What is happening in the places that we implement these interventions that are facilitating that these changes in health outcomes happening. So that is the focus, that is the core of implementation science. Understand how implementation strategies are implemented and how that support those implementation outcomes. How by doing this intervention increase the feasibility, the fidelity of that intervention, the penetration, how is adopted, how is acceptable, not only among the people who are the end user, the patients, but also how acceptable it is among the implementers, the people at the clinic level or at the center level implementing that. What needs to happen for this innovation to be sustained and maintained over time? How much is cost to do that? Do we need to do some changes at that level in order to facilitate uptake? That is the how and implementation outcomes that we try to assess. So my talk is more about that, and sometimes some people say, oh, William, this is a lot of health services research, process evaluation, program evaluation. Yeah, implementation science takes some of the features of that disciplines to incorporate here to assess the how and these implementation outcomes. And I'll make some distinctions in a moment. If you have any question, I have been going to my 10th slide right now. If you have any question, please use the chat box or feel free to ask that at the very end. If you think that you have any questions that deserve attention to me at the moment, just feel free to interrupt me and I'll answer that. I think many of you recognize this movie poster. It's a movie from the late 80s, I think. Yeah, in 1989. This is Kevin Costner playing the role of Ray. Ray was a farmer. He had a cornfield in Iowa, and one night he was walking through the cornfield and there was a voice that he heard just saying, whispering, if you build it, they will come. and he turned around and he saw the image of a baseball player, the infamous White Sox from the 1912. The player was Julius Jackson, and he was thinking about, hey, I think I will build a baseball field, and if I build this baseball field, these players from the White Sox will come and play here. You know, I think if you remember the movie or you watched the movie, you will know that at the very end, after 2 hours of movie, they build the baseball park, and the ghosts or spirits of these baseball players just show up and play a baseball game in that cornfield. Well, that's a really nice story, but the reality is that for so many of our innovations, if we build them, they may not come. And it's very important here because we cannot assume a perfect fit between the innovation or the evidence-based intervention and what people or organizations are looking for. So one assumption that we have, and I think this is the no-do gap, we develop these interventions and we assume that when we test them that they're effective in changing a health behavior or a health outcome, people will implement it. People will come to us asking to implement that intervention or that innovation. That is the field of dreams case that is not happening in implementation science. And there are many reasons for that. And I have this slide here just showing some barriers to implementation. Why, if we know X, Y, and Z program works and works pretty well in similar scenarios, population settings, why people, organizations are not implementing them. So there are different levels here. It's a very nice paper focusing on different levels of barriers. The innovation level, the professional or the person who is the one decided about implementing the thing, the patient level, social context where these innovations will happen, organizational context, or political or economic context that incentivize the uptake of these innovations. And you can see here the description of all of them. So in many interventions or many projects, we do something that is called pre-implementation assessment. And I think that's a very good practice, and I'll show you why in a moment. So we try to understand what are the barriers to implementation, and then make sure that when we do our processes to foster the innovation implementation, we address some of these features. This is a paper by Kennedy. It's a recent paper. This is in the context of exercise oncology implementation in Australia, and she did a very novel assessment of these barriers, and she found the frequency of some of these challenges in their own context. We do a lot of research here in terms of exercise oncology with Katie Schmitz and the one group, and I will tell you that if we decide to replicate the same assessment, we will find different findings because context matter, the population that we serve mattered, the social context, the economic context matters. I do a lot of work with vaccine communication, and if I will be replicating this, I will see a shift in many of these factors. So we cannot assume that the barriers for one type of intervention and setting will replicate or will be the same in a new setting or a new population or a new context, okay? So I think it's very critical that we have a good understanding of those barriers to implementation before we start the implementation of an innovation in a particular setting. And I'll give you some hints about how you can do that. One of the main things that researchers, and I will include myself here, we fail is that we have a poor understanding about the barriers to implementation, because we, again, field of dreams, we assume that if we build it, they will come. We assume that if we have something that works, people will die for implementing that in the clinic, and this is not the case. I want to talk about TMF, theories, models, or frameworks implementation science, because it's really important that when we write grant applications, and I'll show you in a moment how the ISC, or the group that I have been working on developing in the last 2 years, we can help you identify the best TMF for you, identifying the best implementation strategy for you, identifying the best implementation measure that you should include in your grant proposal or your project. But I want to make some introduction about these concepts so you understand the complexity of this field, but at the same time, how our team can help you navigate all this terminology and TMF and measurements, and how we can continue helping you not only with the grant application process, but also in the project management portion of your grants. There are over 60 different theories, models, and frameworks in the field. This was cataloged 7 years ago, but as we speak, there are over 100 of them. So one of the main issues is that, oh my gosh, what's the best one that I should include in my own research? The answer is that will depend on the research question. And the second thing is that most of the time, your project will require not only one, but will require a combination of 2 or more. Okay, and I'll show you in a moment some example. Many of these TMFs are borrowed from other scientific fields, and I'll show you those next slides. But some are uniquely developed for implementation science, and how they can be used. They're very useful to inform your hypothesis. If you are submitting a grant to with focus on D&I, your hypothesis should be informed by your TMF. It's also helpful to understand processes or behaviors to be studies. Identify potential barriers and facilitators. We were just talking about that a moment ago. Will help you to identify what's the best implementation strategy to facilitate that process and the selection of measures and outcomes. And I put a lot of word in here: barriers, strategies, measures, processes. All these are important, and I think where you should start working on your grant application for a D&I project is with the selection of that TMF. And the reason why, because it's a very important paper published by Proctor 10 years ago, and shows you what are the 10 key ingredients for implementation research proposals. And I have reviewed some of these proposals, and basically this is our Bible when we are reviewing those proposals. So we want to see these 10 key ingredients there. And you can see here, number 3 is you have to justify, you have to specify your conceptual model or theory or framework. And again, most of the time you would require to combine multiple TMF in your proposal. But at the same time, you're seeing here on green, implementation strategies and measurements. The selection of your model, theory, or framework will guide you to select the strategy and the measurements of your project. So I think it's really, really important that you have a good selection of your TMF, because as you're seeing here, among these 10 ingredients, 3 of them will be dictated by the selection of your TMF, okay? We were talking a moment ago about pre-implementation assessment, how we should be understanding the barriers for implementation. And that's exactly number 4, okay? And I think I want to connect number 4 with health equity. It's very important that you engage stakeholders or implementers or potential end users to help you identify those barriers and facilitators, to help you guide the implementation of your project. I'm working with Dr. Krasnelski in multiple projects. PCORI is heavy on the engagement of stakeholders, but lately I have been working with other people in NIH proposals, and they are doing the same. They're looking for the engagement, meaningful engagement of stakeholders, not only patients, population, but also they want to see people with experience implementing these in similar settings, how you can involve them from pre-implementation assessment to implementation processes, and at the very end, in the dissemination of your science. At the same time, look at number 5 and number 7. Okay, we were talking about have a good understanding about the barriers. okay? So in order to have a good understanding about the barriers, you need that. Because in number 5, you have to show in your proposal that your setting is ready to adopt this innovation. And number 7, as you can see here, that there's people with experience in your team doing that implementation process. Understanding those barriers will help you to answer number 5 and number 7. So there are multiple things that my team have been working with other co-investigators, specifically to help you writing these key ingredients, number 3, number 6, and number 9, more specifically. There are many theories, models, and frameworks as mentioned. There are more than 100 of them right now, but you can group all of them into these 5 main buckets: process models, determinant frameworks, classic theories, implementation theories, and evaluation frameworks. Again, you can choose more than one, not only in the same bucket, but across these different buckets. And depending what is the goal or the research question you want to address, you will select 1 or 2 among these buckets. Some of you have heard about CIFR, and I give you here some examples of these TMF. Of course, the one that I feel more comfortable with, and the one that I have been working with other co-investigators. So that's the reason I am presenting 3 examples right now. There are many more. Other investigators have different preferences. I think the important thing in your grant application, if you want to do that, is that you justify why this TMF is the most appropriate for my research question. Okay, I don't think there's one better than other. That will be dictated by the research question that you plan to answer with your project. Okay, CIFR. I use CIFR a lot when I am particularly interested to have a better understanding of the setting. When I want to focus on the inner setting or the outer setting, how that impact the adoption of my innovation, I use CIFR. CIFR provides a really good guidance about the constructs to assess the outer and inner setting. The same for the intervention and the individuals involved, but I have found that CIFR, at least for my projects, is really helpful to understand the setting. One of the main issues here, you can see processes. Processes seems not well connected or well defined with the setting where you plan to implement. That is the reason that when I want to try to understand the processes, I don't use CIFR. I use a different TMF, and this is EPIS, the Exploration, Preparation, Implementation, Sustainment Framework. And as you can see here, and I want you to look at the overlapping circles that are inside this model, you will see a few things here. Outer context, inner context, innovation factors, that's the intervention, okay? So those 3 things are the same as here, as CIFR. The main difference across these different TMF is that EPIS give a better direction about how you measure and evaluate those processes, how you move from one domain to another domain, and how those domains are related, the linkages among those domains. So I have found that EPIS, at least for my own projects, is more helpful if I'm more interested in these processes of implementation versus if I want to measure setting constructs itself. Okay, so if I want to measure setting, I prefer to go with CIFR. If I want to measure processes, I use EPIS. Okay. Another very useful, and I think you should have heard about the REAIM framework multiple times. I like REAIM because REAIM gives you a lot of flexibility. I think in all RCTs or all interventions, regardless if you're doing an effectiveness or clinical trial, maybe without taking into account implementation research, I think it's very important that with your trials, you try to answer these five questions. Okay, it's very flexible. You know, how do I reach the target population? You know, it doesn't matter if you are not interested in implementation research, But I think it's important for your own clinical research or RCT that you evaluate if you're capable of reaching your target population or the characteristic of that population. If I am intervening with populations in Reading, Georgia, Lebanon, with large numbers of Hispanics, at the very end, I would like to see if I was able to recruit large number of Hispanics. So reach is going to give me, questions or measures around reach in the re-aim context will give me the information if I was capable of reaching the target population that I was intended for. And the same, you can apply the same 5 re-aim domains, regardless if you are doing or not doing an implementation research. I think it's really important that you try to answer these 5. Actually, one is the effectiveness question. So the last thing that I want to just mention is how you select one of those TMF. Again, is informed by your research question or your objective or your study. My own experience and people who work with me know that I prefer to use CIFR, EPIS, re-aim. I feel very comfortable with those 3 TMF. And I think equally important, they're commonly referenced in NIH and PCORI grant applications. So reviewers also have a really good awareness about these 3. I work with some of you in a couple of PCORI and NIH funded RCTs, and we have been having a great success writing the implementation evaluation of these RCTs using re-aim, using CIFR, and more lately using EPIS. So we have specific language for grant proposals that we offer to investigators when we write those sections for your grants. Equally important, grant applications typically include at least 1, if not more than 1 TMF, and I'll show one example very soon. If you would like to explore all these different TMF and maybe play a little bit about what's probably the best TMF for my next project idea, I'll encourage you to go to this website. You will be able to, it's an interactive platform, and you will be able to answer a few questions, and this website will recommend you some TMF that you can use, and constructs or domains that you can explore, and that will include you some information about potential measures that you can assess. So basically, this website will help you to identify potential TMF and measures aligned with those domains or constructs. So it's a really good resource. TMF is one thing. We also talk about implementation strategies. If we can go back to what I mentioned like maybe 10-15 minutes ago, the thing is the evidence-based intervention, but the implementation strategy is the stuff that we do to implement the thing in the setting. Okay, there are many implementation strategies. If there are 100 TMF, there are another 100 implementation strategies to choose from. Okay, so this is a very important paper from Waltz. They summarize again in 9 buckets of different implementation strategies that you can apply or you can use. More recently, I was working with one of our co-investigators, Deep Sakar, and there's a new paper about implementation strategies focused on school settings. So I think it's really important that we have an overall catalog of implementation strategies to be used, but I think it's equally important that some other researchers in the past years, they have been working to refine those implementation strategies to selected settings. So if you are writing a grant application, as we were working with Deepa Sakar, and you are working on the school setting, and you propose an implementation strategy that worked pretty well in a clinical setting, but not in a school setting, reviewers who are aware of this field will notice that, and you will run into a problem. So understanding a lot about the literature, and understanding a lot about the field in terms of the selection of these implementation strategies is key in order to get good reviews. It's not only about, hey, I want to give an example here. In one of my ongoing trials, I use Project Echo, or the Echo model, as my implementation strategy. I use that as a telemetry tool to deliver my evidence-based intervention called the announcement approach. It's not only that you define Project Echo as your implementation strategy, I name it. I name Project Echo as my implementation strategy, but I have to define it. Why Project Echo is my implementation strategy? Because it offers telementoring, because it offers practice facilitation, because it offers opportunities to discuss issues and evaluate progresses. So I was just able to answer the first two things. I name it and I define it, but then you have to specify it. You know, the actor, the action, the temporality, the dose, how many times do you have to apply this implementation strategy? What is the implementation outcome that you plan to assess, and the justification? So again, going back to how important it is to report these in grant applications, one thing is that you justify your evidence-based intervention. But another thing is that you have to justify and be very specific about the implementation strategy. And you also have to be very specific about defining your TMF. Okay, so there's a lot of moving pieces in these proposals that people have to take care of and put the correct language in order to be successful. I'm not spending time in terms of study design considerations. I offer a prior seminar a year ago, and I can go over all these details if you want for another talk. But what I want to just mention here is that there's something called effectiveness implementation hybrid designs, and these are specific designs to answer both effectiveness and implementation research questions in one single experiment or randomized control trial. Okay, we have a nomenclature, we call them type 1, type 2, type 3. You will see the distinction now. And the reason for these hybrid designs is to accelerate the transition from effectiveness trials to implementation trials. And different from other study designs, these are very unique to implementation research. I'm gonna skip this slide. I think I spent some time already just discussing the difference between the clinical trial and the effectiveness trial versus implementation trial. But what I want to show you here is why it's important to do these hybrid designs. Because in our usual science, we go from pre-intervention, more observational studies and getting the pilot data, to efficacy studies, and then we move to effectiveness trials. And right after we found that the intervention, the program, or the innovation is effective, then we do our D&I studies. Okay, so going through that process takes so many times, years. Okay, hybrid designs are designed to speed up that process, combining effectiveness and combining implementation questions in one single trial or one single study. And this is the way that you can make a decision about what hybrid design is more appropriate for your own research study. You see here this example, hybrid type 1, 2, and 3. If you are, this is a rule of thumb, we can have a discussion about this later. If you are more interested about the effectiveness of your innovation or intervention, but at the same time, you want to collect some information about the implementation, you go with a type 1. You're more interested in testing the effectiveness, the impact of that innovation, but at the same time, your secondary goal is to get some promising information about the implementation outcomes. Okay, I'm going to skip to number 3 now. I'm going to keep number 2, type 2 for later. If you know that your intervention works pretty well, there's solid evidence, and you're more interested in the dissemination and implementation of that innovation, then you move to a type 3. You're more interested in understanding how this can be implemented in different settings and in different populations. And then you will collect as a secondary outcome information about clinical outcomes, okay? So the question is, if I'm doing this intervention in a large healthcare system, I already proved it works pretty well. There's 10 randomized controlled trials showing that this intervention works pretty well in a large healthcare system, but you're now interested in moving to more independent FQACs or small or medium facilities outside the original setting where this intervention was tested effective, is when you do a type 3 design, because you are more interested in understanding implementation aspects, because you know it works, okay? So the question is how this can be replicated in other settings. If you want to answer both questions about the clinical impact, but at the same time, the implementation processes, then you do a type 2 design. And I'll show you my example about my R37, my HPV echo trial. It was designed as a type 2 design. I had evidence about the effectiveness of my trial, of my innovation. I was making some changes to that innovation, some adaptations. I knew that Project Echo is an effective implementation strategy, but the issue is that it has never been used for vaccine communication studies. So I really want to answer 2 questions. If I modify the announcement approach training, the evidence-based intervention, to be delivered through Project Echo, how effective it is, and at the same time can be implemented in that way. That is the reason I use a type 2 design, because for my own specific research study, I needed to answer both questions at the same time. So I designed a trial with the capacity to answer both implementation and effectiveness questions during the same 5 years. Now I want to change a little bit. I want to spend a few minutes here. What my team has been we have been developing for the implementation science collaborative in the last 2 years. We developed this with one mission, and we have identified that there's limited capacity among faculty, trainees, and our community partners to implementation science. So our mission is to build capacity infrastructure among our faculty, trainees, and community partners to apply implementation science to speed the use of evidence-based practices in clinical and community settings to advance health equity in our region. So that's our mission. One is to build that capacity at the College of Medicine and hopefully through Penn State, through the CTSI, but at the same time, outside that organizational capacity is to advance health equity through the implementation of these innovations in our region. We have 4 areas of focus that we have been working in the past 2 years, and we would like to expand. We have been doing, number 1, our own studies to advance the field. And I'll show you a few examples in a moment. We have been able to provide consultation to faculty and trainees with great success, helping at this point 4 colleagues to get their proposals or applications funded by PCORI and NIH. We have been also working to increase awareness of and capacity for implementation science at Penn State University, doing this type of talks or meeting with research teams. And the 4 areas of focus that we have is to provide opportunities for education and training. One of the things that we're going to be doing, me individually as a PHS faculty, I'm going to be seeking approval for a 3 credit course on implementation science to be offered in College of Medicine and University Park. So just to give you one example. Another thing that we're going to be doing for education training is doing more seminars like the one that we're offering right now. What we have accomplished in terms of these 4 focus areas in the last 2 years. So I'm showing you some accomplishment in the last 2 years. My team, we have received 3 grants. 2 are ongoing and 2 are external, and 1 is internal grant, totaling $2.5 million. So that's me as a PI. I have been working with other colleagues at the College of Medicine, Dr. Krasnowski, Dr. Pichardo-Loden, and Dr. Katie Schmitz and McRuffin, helping them writing and developing their implementation aims for their RCTs, and they have been able to get awards, 4 of them, totaling $14 million. And there are 2 other co-investigators, I can PIs here. I cannot mention them right now. They have promising scores for 2 large PCORI grants. So hopefully by the end of this year, this number will increase from 4 to 6 grants awarded. Only on terms of implementation science papers, we have published 6 of them in the last 2 years. We have been offering more than 10 talks, not only internal talks like this one, but at different conferences. And I'm very happy to include doctoral and junior faculty trainees in my team. More recently, very proud to support one of our junior faculty, Susan Baldier, helping and mentoring her as she's going to be learning about implementation science and the application of implementation science in her own project. This is one of some of our accomplishments in the last 2 years. Some highlights about our own projects. I mentioned about my own RCT, HPV Echo. I mentioned it's a hybrid type 2 design. I want to navigate this quickly here. I mentioned before that sometimes you have to use more than 1 TMF in your own project. This is my case. In this particular project, I combine CIFR and Proctor's implementations outcome framework. I don't have a lot of time to go over this, but as you can see here in my model, I am using the ECHO model as my implementation strategy to deliver 2 evidence-based innovations: the announcement approach training to improve the communication skills of clinicians to recommend HPV vaccination, and systems communication to follow up those parents who decline vaccination. I assess those interventions characteristics using CIFR measures. And at this time, as we deliver our intervention, we're in our 3rd year, we're assessing key implementation outcomes. We're more interested in cost and some implementation effectiveness as well. And these are more adoption measures if you want to see them. And at the very end, we plan to see some patient outcome changes in terms of HPV vaccine initiation. So again, we define our implementation strategy, our evidence-based innovations, actually 2 of them. We were very specific about the implementation outcomes that we want to assess. These are proximal and these are distal. And at the very end, we are getting information about changes in HPV vaccine initiation. So this is our effectiveness information, and these 2 are our implementation research information. We're collecting information about the inner context and information about the outer context as well from multiple sources, not only from the clinical records data, but also interviewing clinicians, interviewing patients as well. This is a mixed method evaluation that we're doing here in this hybrid type 2 design. You don't need a large R01 or large R37 to do implementation research. I'm really grateful that a year ago or 2 years ago, I received one of the CTSI registered translation for pilot awards to do some implementation research, translating clinical risk assessment tools to a community setting. This is a very unique project because we were able to implement a community to clinic referral approach in a 211 call helpline. These are not settings that used to deliver health innovations or health interventions, but we were able to do a referral process. And what we want to try to understand is how feasible is to do this type of referral approach. And what we found is that among the 1,000 participants that agreed to participate in our pilot project, we were able to identify 66% of them in need to a referral to any of the 3 diseases of despair behaviors, for drug abuse or overdose, for alcohol abuse, and suicidal behaviors. And among those people, 39%, they accepted the referral. So in this pilot implementation study, we were able to show that it is feasible to do this community to clinic referral approach. And that is really important because this is translating evidence-based tools that are used in clinical settings to be applied in a non-clinical setting to identify people at risk and refer them to appropriate healthcare services if they need that. Okay, so you don't need to have a large grant to start thinking or doing some work on implementation science. You can do some of these pilot studies if you're interested. And actually, this is very important because this serves for me as a pre-implementation evaluation for my next grants, and I plan to increase do more research in this space. Some examples here about my active projects and the projects of my colleagues. And in terms of future directions, we plan to offer consultations, or what we call ISC studies, at no cost. And this is through Penn State, through the Penn State CTSI. Thank you, Dr. Krasnodki, for allowing us to do this. And what we're going to be doing through these consultations is, as mentioned before, and I hope you have a better understanding about how important this is. I talk about implementation research questions, selecting your TMF, implementation strategies, what study measures you can use. I mentioned a lot about how important it is to be very clear in your grant applications. So our no-cost consultations will include, will provide you with all this information. And at the same time, we can also offer some project management support. So that is our goal in the next years as we move our ISC to be integrated into the CTSI core offering. We also plan to do more of these seminars, but with a specific focus on how we can integrate this with the KL2 program. I think it's very important that our junior faculty and doctoral students, they apply implementation science in their own studies. And also we plan to develop our formalized work group in the next years. I have been working a lot individually with many faculties, but I would like to assemble a 10 people, 12 people, researchers and trainees with a focus on implementation science, so we can develop a shared research agenda for CTSI, for the College of Medicine, and for Penn State. That will be my goal in the next year. This is our team. I'm very happy to work with these people, my staff and my students. And these are the collaborators or my colleagues. I have been helping all of these people, working with all these people, getting grants, grading papers in different capacity. And this is another of the new people that I'm working with or lately. And if you have any questions, feel free to email me or email Chelsea Keller, who's the project manager for the ISC. And if you want to learn more about what we're doing, please visit our website. And this website in the future will be integrated with the CTSI website. So I only have 5-8 minutes to answer any questions. So happy to answer any question or any comment that you may have.
Well, thank you so much, William, for an absolutely brilliant presentation. I'm sure everyone else enjoyed it just as much as I did. We do have one question from Ashley Stauffer in the chat, and everyone else, feel free to put it in the chat or raise your hand and we can answer that. So Ashley's question is, how do you measure penetration? Is this something that is predefined in one of the TMFs or something you determine based on the specifics of the study? If it is something that the study determines, what are typical measures that are used?
Yeah, I think this is a really good question. For penetration measures, I think the best paper to read is Proctor's implementation outcomes, and penetration is a construct that is in the middle of adoption and sustainability. Adoption is the initial uptake of the innovation, but it's not about sustainability. Penetration are what processes are happening in that setting that the innovation is integrated into the actual workflow. So a few things that you can measure with that one is, in my own case about vaccine communication, we know that clinics, they have monthly team meetings or huddles. So our concept from vaccine communication that I train clinicians during my HPV echo training are discussed during those monthly meetings. Or are the clinics adopting some kind of clinic level policies or procedures to make sure that that's sustained? So this is not measuring sustainability over time. This is just measuring what is happening at the setting level to guarantee that the initial adoption will be integrating into the workflow. I hope that answered the question.
It does. So, thank you so much.
Good. And there probably penetration is one of the most difficult implementation outcomes to assess, because I think I mentioned is sandwiched between the initial adoption and sustainability. So I think penetration is kind of the bridging construct between those two.
That makes sense. And it's something I think about all of the time. So I really appreciate your response and the mention of the article to look further into. appreciate it.
Yeah, if you look to my slides, it will be available. You can look at the when I mentioned Proctor implementation framework, and that will give you more information.
Any other questions from the group? So thank you, Jocelyn. She put the ISC website, current website in the chat for you, as well as the D&I models web tool that was mentioned in the presentation today.
I also want to mention that I focus a lot on quantitative measures because I do that, but more recently I've been working a lot with QM&C. There's an interest, at least from NCI, to do case studies and qualitative studies to answer implementation science questions. So although we have a lot of scales and a lot of measures that we collect at the clinic level, there's also value to integrate qualitative and mixed methods in your implementation science. And LG Banskoy, she's very aware of implementation science as well. So if you would like, if that's something that the people are not very aware, the importance of measure things outside traditional scales. So please consider that, because there's an interest in NIH to get that kind of information now.
So with that takes us to the end of the hour. Thank you again, Dr. Calo, for a fantastic presentation. Absolutely delighted to be able to feature you and your team's hard work here. And thank you everyone for attending. It was wonderful having you here today. Join us next month.
Thank you.